Hello everyone, my name is Rob Sherman and I'm one of the product managers here at Sonora Quest Laboratories. In these unprecedented times, patients, especially the elderly and those with a history of heart disease, are at particular risk of adverse outcomes with COVID-19. There has been long-term recognition that viral infections may lead to an increase in risk for heart attacks. And so today we'll be bringing you a cardiovascular clinical conversation with our distinguished guest, Dr. Mark Penn. Dr. Penn is the founder of Cleveland HeartLab. He is also the director of research at Summa Cardiovascular Institute and professor of medicine and integrative medical sciences at the Skirball Laboratory of Cardiovascular Cellular Therapeutics at Northeast Ohio Medical University. And somehow he still finds time to be a practicing cardiologist and sees patients on a regular basis. So, Dr. Penn, welcome and thank you for joining us.
It's my pleasure to be here. Thank you for the invitation.
Great. So, Dr. Penn, as I said in the opening, we are living in unprecedented times. Heart disease continues to be the leading cause of death here in the United States. And we know that viral infections such as influenza or COVID-19 can have a profound impact on patients with pre-existing cardiovascular disease. So my first question is, what role do viral infections play in vascular inflammation?
While we all think about cholesterol as the driver of cardiovascular disease and heart attacks, the reality is what causes a heart attack is inflammation of the vessel wall. And ultimately that vessel wall rupturing, not unlike a pimple on the face, but when it ruptures on the inside of the artery, it causes a clot to form, and that is what causes a heart attack. So anything that drives inflammation in the body, even rheumatoid arthritis, increases our risk of having a heart attack. In particular, respiratory viral infections like the flu clearly have been shown to increase the risk of a heart attack. And in fact, a study in the New England Journal of Medicine in 2018 showed that in the week following a positive viral titer, the risk of having a heart attack is six-fold compared to any other time a year before or a year after. And that risk lasts for about 8 days. So inflammation drives heart attacks, and patients who have uncontrolled risk factors are certainly at increased risk of having a heart attack, not just because of COVID-19, but influenza as well. And it has been well recognized over the last several years that a very potent way to prevent second heart attacks is to get a flu vaccine every year.
So one question that I hear a lot in the field is, how long does COVID risk for an MI persist once the viral load has cleared?
Yeah, so we know for influenza, it's about 8 days. I think once the viral load clears, there's probably less risk of a heart attack, but we really don't know whether it's a week or 2 weeks as of yet. But we know during the acute inflammation and the acute disease, there's clearly an increased risk of a heart attack.
One question that I'd like to ask you is, how can healthcare providers identify those patients at increased risk for a cardiovascular event with viral respiratory infection?
Yeah, and this is a big issue, in particular in the setting of COVID, where folks are not going out, they're not exercising as much as they were, they're probably not eating as well, and they may not be taking their meds or getting their meds like they were. So the real question is, who's at risk, and try to minimize that risk before or if they were to get COVID. And the way to do that is to minimize risk factors. And most specifically, it's to minimize vascular inflammation in those patients and identify those patients who may have evidence of what we call vulnerable plaque, again, these pimples on the inside of the artery wall that could rupture. Right. And using markers of vascular inflammation like myeloperoxidase or LPPLA2 is really key.
That leads me to my next question, which might be at the crux of our discussion is, are there any tools, or can you share with us some of the tools to monitor therapeutic response once it's been identified?
Yeah, and so one of the things we've done at Cleveland HeartLab and now Quest Diagnostics and with Sonora Quest is develop tests that define not only whether the patient has risk, but what the acuity of that risk is. And in particular, ADMA, asymmetric dimethylarginine, and myeloperoxidase, or MPO, define nitric oxide bioavailability. If that is low and there's clear evidence in COVID that there's an endothelial dysfunction component to the disease. If nitric oxide is low because either of those markers are up, you have a patient who's at higher risk of an adverse event if they get COVID. When you add MPO and LPPLA2 as markers of vulnerable plaque, again, another patient type who is at high risk of having an event if and when they become inflamed. So really specific to COVID or influenza, it's ADMA, myeloperoxidase, or LPPLA2.
If I heard you correctly, and maybe this is a different question, but can COVID-19 itself, cause formerly normal levels of myeloperoxidase or LPPLA2 to become elevated and thus put the patient at increased risk?
They may become elevated in response to COVID, but if they're already elevated because the patient has high risk, then they are likely to do worse if they get COVID. The idea is, and what we recognize now, is patients have vulnerable plaque. We all have some level of vulnerable plaque. Thankfully, we tend to heal that. If you get a COVID infection and you're less likely to actually heal that and more likely to go on to rupture and have a clinical event. Okay. So what we really want to do is have patients with limited vascular inflammation when they get COVID to minimize the risk of plaque rupture and a heart attack.
Okay, that makes perfect sense. And so from a primary care perspective, let's say I have an asymptomatic patient with multiple comorbidities and elevated levels of LPPLA2 and MPO or myeloperoxidase. Does there come a point when that patient should be referred to cardiology?
No, it's really about prevention. And that prevention is either lowering lipids a little bit more, whether they're on a statin or not. If their hemoglobin A1C is maybe pre-diabetes, maybe you still treat it because you need to drive insulin levels down. It may be, and particularly germane in what we're going through now, they haven't been to the dentist in over a year and they have periodontal disease or periodontitis, and that drives vascular inflammation. The key here, though, I think, as we look at our panels of patients and we're trying to sort through who do we really need to see and who doesn't have to come in for a quote unquote a wellness visit in a setting of COVID, those folks who have high markers, if you get those first, are people you need to see because they may be eating poorly, they may be off their meds, they may not be exercising, and because of all of that, they're driving vascular inflammation and putting themselves at an increased risk of a heart attack just in normal times, and particularly an increased risk if they were to develop COVID.
So along those lines, is there a certain dietary protocol that you might recommend for combating inflammation? And what are your views on the Mediterranean diet for patients that fall into this category?
Certainly a Mediterranean diet is something of interest. Forks over knives, put forth by Caldwell Esselstyn, and the idea that you never eat anything that had a face or a mother, which is really a vegan diet at some level, really has been shown to drive down markers of vascular inflammation. My teaching when I talk to patients is you didn't get here overnight. You're not going to get back to normal overnight. You need to start with moderation, minimize particularly sugars in your diet because of the prediabetes, diabetic, and obesity epidemic in America. It's really sugar and insulin that is driving our disease process. Lipids are certainly an important part of that, but we really need to drive sugar out of our diet, lose weight, exercise, and minimize really metabesity or metabolic dysfunction.
Absolutely. And we live out here in Arizona where the sun is shining brightly well over 300 days a year. And so a question that comes up quite frequently is what role does vitamin D play in the vascular inflammatory process? Can you share that with our audience today?
Despite your 300 days a year of sun, all the sunscreen we all wear, which is important for a lot of reasons, limits our vitamin D levels. It's always remarkable to me how low vitamin D levels can be, even in Florida and in Arizona. As you can probably see behind me, I'm sitting here in snow, so I'm not worried about sun. Vitamin D's role is controversial. There's reasonable evidence that it helps with blood pressure control. If you control blood pressure, you decrease inflammation. So it's worth checking, particularly in those who are particularly low. But not everyone will agree with that.
Okay. And then, when we talk about plaque, I wanted to get your views on what you think about tracking plaque with carotid IMT. Not necessarily a calcium score, but in addition to looking at cardiovascular inflammatory markers.
It's pretty well established that if you have somebody with a high calcium score and you put them on a statin, that calcium score will either stay the same or go up.
Okay.
They don't get better. So it's hard to follow the disease. Neointimal thickness or intermedial thickness does change with treatment. That's the value of it. Your intima will get smaller, you'll see less fat or plaque on the carotid wall, and that's really valuable and tells you that your preventive strategies are working. The challenge with IMTs is that they are user specific, meaning you really need a highly skilled sonographer who's going to get you very similar measures repeatedly. And that's hard to come by at times. The nice thing about blood-based biomarkers are they can be followed over time and they will change. If you decrease vascular inflammation, you will decrease myeloperoxidase, you will decrease Lp(a)2 levels. And we have very good data that hopefully come out this spring that shows that if you decrease MPO by 100 picomoles per liter, you actually decrease mortality by about 4% over 6 years. So that's really important data. So IMT is great. It's just hard to get.
And you touched briefly on some of the therapies. Going back to the times we live in with COVID. What are your thoughts? Is 81 milligrams of aspirin very common therapeutic, but is it recommended for somebody with a viral infection such as COVID-19?
It's more importantly recommended for folks who have cardiovascular risk. Even if you go back to the physician health study by Paul Ridker a number of years ago now, what Paul showed was if you were on the 4th quartile of HSCRP, you had a several-fold increased risk of having a heart attack. But if you took an aspirin, you significantly decreased that. Conversely, if you were in the 1st quartile of CRP and you took aspirin, you had no benefit because you had no risk. So in patients who have high MPOs, have high Lp(a)2s, have vascular inflammation, or are at risk of heart disease and get COVID, I think aspirin makes a lot of sense. Low risk patients don't benefit from aspirin and only get the risk.
Okay. So in wrapping up, doctor, obviously, we're doing this talk today because the times we live in. Is there any final thoughts you would have for us around, just maybe summarizing the role that the viral infections, in particular, something disease like COVID-19 can have on patients with existing heart disease, and maybe send us share your final thoughts on what we can do to monitor and mitigate that risk.
COVID, from a cardiovascular risk point of view, has highlighted, certainly for me, we deal with this every year during cold and flu season. Yeah, we've learned a lot and we have to be highly focused because COVID's around right now. But we should not forget this. And we should remember every fall as our patients enter cold and flu season that they get their flu vaccine to protect them. And we mitigate their risk by lowering their MPO, their Lp(a)2s, their ADMAs, optimizing their diets, getting their blood pressures controlled. Because going into cold and flu season is when they are at greatest risk. Because if they get the flu, they're at a much higher risk, again, 6-fold increased risk of having a heart attack.
Great information, doctor. Really appreciate you. And for all of you that are watching, I'd just like to thank you for joining us today. And my special thanks to our guest, Dr. Mark Penn. So thank you, Dr. Penn.
My pleasure. Thank you.
If anybody that's watching out there has any questions, I'd like you to feel free to direct them to me. I can be reached on my email at rob.sherman@sonoraquest.com. Otherwise, please join us next time for part 2 of our conversation with Dr. Mark Penn, when we'll discuss the role of vascular inflammation in cardiovascular risk assessment. Again, thank you all and be healthy.